very good evening to you all. Delighted to be here for this session on gallbladder cancer. I am Dr. Adiba Nizam. I have completed my post-graduation in general surgery and my secondary DNB from Maulana Azad Medical College. And today I'm working as a senior resident at Lady Harding Medical College. So today we have this lecture on gallbladder cancer. However, I would like it to be more of a discussion than a lecture. And that depends on the participation from students that we have here, whether we have a lecture or a discussion. But let's try and have a discussion. So if you have any questions in between, either raise your hand or type them in the chat box. And we'll take them up as we go along. About gallbladder cancer, like why is it important? There are two concerns. One that we have as a student, like why is gallbladder cancer important to us as a PG student? And then the other one is why is it important to us as a clinician? As a PG student, when you would be giving your theory exams, it is a question that is asked in your exams about the clinical features and management of gallbladder cancer in university and DNB exams both. And when you would be appearing for your clinical examination and you have a case presentation on obstructive jaundice, one of the differential diagnoses is a cancer of the gallbladder presenting with obstructive jaundice. So as a student, it's an important topic to know about. Then as a clinician, when you are in clinical practice, especially in Northern India, it is a very common malignancy. When you would be reading books, it'll say that it's a rare malignancy because in the West, it is a rare malignancy. But for Indians, we are second only to Chile in terms of the incidence in the ethnic populations. So it is a very common malignancy that we see on a day-to-day basis in the clinical setting. So knowing the management of gallbladder cancer and how at each stage we have to manage it is important. So we have to know about the etiopathogenesis of gallbladder cancer, the clinical features of gallbladder cancer, then what is the staging, and how are we managing gallbladder cancer. So we'll start in a different order and we'll see if a patient is coming to us with gallbladder cancer, what are the different ways in which this patient can come to us. So in our first scenario, we have the 68-year-old gentleman with complaints of jaundice for 3 weeks. And he has also dark discoloration of urine, itching, and pale stools. With this clinical history, can anyone tell me what sort of jaundice are we dealing with? What is the type of jaundice that based on history you would suspect in this patient? Okay, so I guess I'll give the answer. It is the obstructive jaundice. So on further examination of this patient, we have no hepatomegaly or lump. On ultrasound, there is bilateral IHBR. The proximal CBD is dilated, and there's a GB mass infiltrating the liver. Yes, Alpna, you're right. It is a picture of obstructive jaundice. And here, it's an obstructive jaundice without a palpable gallbladder. And on imaging, we have a mass in the gallbladder. This is one presentation that one patient has come to us with. Then, moving on, on the second case, we have a 52-year-old lady. She has undergone an uneventful laparoscopic cholecystectomy. And now she's following up in the OPD, and she's come to you with her biopsy report. And this is the biopsy report. So we have an incidentally detected gallbladder cancer, and it's an ulceroproliferative growth. It's an adenocarcinoma. There are 2 regional lymph nodes which have also been identified in this specimen. And the P staging of the tumor is given as P2A, N1, and MX. Going on to the third case, a surgeon is performing a cholecystectomy and encounters a suspected case of a gallbladder cancer. What is to be done now? And in our fourth scenario, we have a 40-year-old lady who is being evaluated for right upper abdominal pain. On the ultrasound, we have an irregular GB wall thickening. A CT is done, and a diagnosis of a gallbladder malignancy is confirmed. She undergoes staging workup and is planned for a curative extended cholecystectomy. So we have these 4 scenarios of 4 types of patients which are all presenting with gallbladder cancer, however, with different stages of the gallbladder cancer. And for each of them, the management is different. So that's what we are going to be discussing in the further slides. How, for each of these stages, how will we stage each of them, and how will the management change with each stage? So to review, I'll come back to your question a bit later when we are discussing the etiopathogenesis of it. So surmising the clinical findings that we can find, most of the times in gallbladder cancer, the clinical features are very non-specific. Like the patient might have no symptoms at all, or when the patient has symptoms, these are very non-specific symptoms like right upper abdominal pain, which mimics the pain of biliary colic or cholecystitis, more often cholecystitis pain. And the other presentations, as we have discussed, are these: suspicious mass during surgery, an incidental finding on the pathological review. We find a mass on imaging. There is, in some cases, which is most of the time, we'll not be detecting gallbladder cancer early because there are hardly any symptoms or non-specific symptoms. And when these patients do present, they have an advanced stage of disease where they will present with the jaundice, anorexia, weight loss, and signs and symptoms of metastatic disease. So next, as we're discussing now, the etiopathogenesis in gallbladder cancer is mainly chronic inflammation. There is a adenoma to carcinoma sequence, as we see in other cancers, and the driving force here is your chronic inflammation. There are some risk factors, as you all know, with increasing age. Sex, female sex has a preponderance for gallbladder cancer. Then ethnicity. As I have told you, the highest incidence is in Chile. The Machu Indians in Chile have the highest incidence, followed by women in northern India. We are a high-risk ethnic group. All these other factors that I'm listing down below, as cholelithiasis, porcelain gallbladder, a GB polyp, congenital biliary cysts, and abnormal pancreatico-biliary junction, chronic inflammation with Salmonella typhi, Helicobacter, and hepatitis B. And then we have carcinogens, primary sclerosing cholangitis, and inflammatory bowel disease. All of these are leading to chronic inflammation in the gallbladder mucosa, leading to KRAS and P53 changes, and further on leading to the adenoma-carcinoma sequence, turning it into a gallbladder malignancy. So as Alpna had asked about the GB polyp, yes, there are risk factors with GB polyp that the GB polyp can turn into a malignancy. The incidence of adenomatous polyps is approximately 30%. So, which would eventually be turning into a GB adenocarcinoma. So for GB polyps, the rule is when we have a polyp which is greater than 1 centimeter in size, we should offer laparoscopic cholecystectomy. Other factors to consider are patient age. If the patient is elderly, we should consider cholecystectomy. Then the number of polyps, the lesser the polyps, the higher is the risk. So less than 3. The highest risk is with a single polyp, which is greater than 10 millimeters in size. Then polyp size, and then there's these are the patients we will consider for cholecystectomy. The other, which are not more than 10 millimeters in size, can be offered surveillance, that we perform repeated imaging on them. And if the size is increasing, then we can choose to perform a cholecystectomy. Okay, so the next question is, what is the most common pathological subtype of gallbladder cancer? Who can tell me that?